Hello, everyone. My name is Dana Coulthard, and I am your host for today. I'm with Healthcare for All Minnesota, and thank you for attending our webinar, The U.S. Healthcare System is Broken, Fix It with Medicare for All. The format today is Ann Jones is going to be our presenter, and she will be doing some introductory slides for about 15 minutes. Then we will be showing the short video, Medicare for All with Dr. Ed Weisbart. Then we will be, Anne will be showing some additional slides after that, and then we will have our Q&A and a call to action. So a couple of technical aspects with this. If you'll notice at the bottom of your screen, if you move your mouse to the bottom, there's a menu that pops up, and there's a Q&A box. And that's where you'll submit any questions you have, and then I will moderate the questions during the Q&A portion. I'll be reading them and posing the questions. And then I also wanted to remind you to adjust, if you're having any trouble hearing the video when we play the video or hearing Anne, remember to adjust your own volume on your computer. And then I also wanted to mention that this is a first in a series of 3 webinars. The next one will be July 15th. It'll be in a similar format with a different video called Medicare for All, How Do We Pay For It? And then August 5th, we're planning on the 3rd in the series, which will be Canadian Healthcare, Debunking the Myths. So at this point, I want to turn it over to Ann Jones, who is a registered nurse and vice chair of Healthcare for All Minnesota. Let me just unmute her.
Hi, and welcome. Thank you for joining us today. I'm going to start off by just mentioning that our Healthcare for All Minnesota organization is working very closely with Physicians for a National Health Program Minnesota and the Minnesota Nurses Association, as well as a number of other organizations in Minnesota and across the country who are working to reform how we pay for healthcare in this country, starting with Minnesota, perhaps. Our challenge is to build that political will for real change. And before we take a look at the video and a solution, I ask you to imagine a world in which none of us ever again had to worry about whether or not we can afford to get health care when we get sick. Hard to imagine, right? In our current system. But imagine being able to start a family, change jobs, start or expand your business, pursue a dream of becoming an artist or a musician, retire when you want, work your farm instead of getting a job off farm, never worry about losing your savings or your home if someone in your family or you get sick, never worry about care for a special needs child or an elderly parent, never worry about opening a medical bill or filling a prescription or getting preventive care. Labor unions could negotiate for pay and pensions instead of haggling over insurance benefits. Everybody would be in, and no exceptions. You wouldn't have to qualify. You don't have to pass an eligibility test. We've got you covered. We are seeing that this COVID-19 pandemic, besides making the deficiencies in public health and our economic system more obvious than ever before, is also highlighting some of the glaring racial disparities in healthcare and in the conditions needed for good health for all of us. This deadly viral pandemic, the inadequacies in our government's response to a public health crisis, and the outrage caused by the racially based injustices in policing that we're witnessing here in Minneapolis and around the country could be a catalyst for change in finally bringing about health justice as part of a broader social justice movement. We invite you to learn more today and find out how you can help. As I said, it's important to understand what the issues were before this public health crisis hit, because those underlying conditions are still there. Keep in mind that these problems existed even during a period of historically low unemployment. If we change nothing, this will persist and possibly worsen, since no one can really predict when we will return to pre-pandemic employment levels. You will hear opponents of change claim that we have the best healthcare system in the world. So if that's true, how is it that so many people can't get the care they need most often because of cost? And why are we the only developed country in the world that ties health insurance coverage to a job, which is really a holdover of World War II economics, despite the high cost and insecurity of employment-based insurance as a coverage model? So in light of what we're seeing with racial disparities and biases in policing, and what we're learning about the disparate impact of this COVID-19 pandemic on persons of color, I'd like to talk a little bit about the disparities in overall health and access to care experienced by persons and communities of color. We're really starting to have to confront the fact that health outcomes for persons of color are significantly worse, whether measured in life expectancy, maternal mortality, infant mortality, rates of chronic disease, cancer, death rates, than their white counterparts. Persons of color are 20% of the population in Minnesota, but 44% of the uninsured before the current high unemployment rates. And safety net clinics are increasingly financially stressed. Majority Black communities are less likely overall around the country to have primary care providers and experience less financial stability for the hospitals in their areas. This COVID-19 pandemic has really worsened a system that is already failing persons of color and the millions of us who are lower income. So here in Minnesota, Blacks make up 6% of the population, but 21% of confirmed cases of COVID-19. Blacks experience higher rates of chronic disease, as we've already discussed, plus more often are in jobs that increase their risk. Blacks are experiencing higher rates of hospitalization and death rates. Other minority groups are also experiencing higher rates of disease. These racial health disparities are really a crisis within a crisis in this era of COVID-19. So what about this pandemic, rising unemployment, and our reliance on employer-sponsored health insurance? Millions of Americans, just within the last few months, are losing not only their incomes, but their health insurance. Now more than ever, the folly of tying healthcare coverage to a job should be becoming quite obvious. Health insurance linked to a job means being one diagnosis or one job loss away from financial ruin. And the short-term remedies that have been suggested so far, mostly at the national level, some here in Minnesota, are complicated and expensive. The irony here, of course, is losing health insurance in the middle of a deadly pandemic. Just by the numbers, we have a system that costs too much, does too little, and leaves too many people out. At $3.7 trillion in total health spending, the healthcare industry currently consumes over 17% of GDP, almost 18%, or 1/6 of an $18 trillion economy. If we do nothing, total health spending in the U.S. is projected to go to $4.3 trillion in 2023 and $5.9 trillion by 2027. Health spending in Minnesota is projected to double over the next 10 years. And none of these numbers account for the cost of managing the COVID-19 pandemic. Just this graph kind of shows that where we stand with health spending per capita compared to other developed countries. We spend 2 to 3 times per capita the amount of money in as other countries which arguably have a pretty high standard of living. What do we get for all this money? Not as much as you would think. We rank a 37th overall in health outcomes according to the Commonwealth Fund. We experience higher rates of chronic disease, and we rank last or near last in access, efficiency, and equity of our system. It will come as a surprise to most people, I think, that 2/3 of health spending in the US is already funded by taxes. So what this suggests is that, contrary to the claims that we just can't afford a Medicare for all system, we really would not have to come up with a lot of new money in order to change how we pay for healthcare. Commercial health insurance is heavily subsidized with taxpayer dollars. This graph from a recent graph from Centers for Medicare and Medicaid Services shows that if you take a look at just the insurance piece of this graph, you can see that only about 1/3 of health spending is from the commercial health insurance sector, and 2/3 is public health insurance. If you include Medicare, Medicaid, which is funded with both state and federal dollars, and other public sources like the VA, Department of Defense, and Children's Health Fund. Also, this graph shows that in addition to private insurance costs and taxpayer subsidies and public spending, out-of-pocket costs in this country are very high. We're still spending an additional 10% of that 3.6 trillion out of pocket. Commercial health insurance is a smaller piece of the pie than most people realize and requires a lot of taxpayer subsidies to work. In Minnesota, the story is that slightly over half of persons covered, 52%, have employer-sponsored insurance, either with a policy or they work for companies who are self-insured. This is lower than I think most people generally assume, but and in particular, the companies that are large enough to afford to be able to self-insure just contract with commercial health insurance companies to manage their plans. So not only do these employers see tax benefits to providing health insurance, but that insurance often helps lower turnover and reduce training costs of new employees. Small businesses, on the other hand, who can't afford to offer health insurance are at a significant disadvantage in recruiting, hiring, and retaining. So we say we care about small business, and we know that small business is an engine of economic growth, but this is really a deterrent to expanding their businesses and slows entrepreneurial activity overall. And then premiums for policies in that small group and individual market are really high, not to mention the out-of-pocket costs for deductibles, copays, and co-insurance. It's important not to confuse health insurance with health and health care. The overall health of a population depends on social and economic factors that many of us take for granted, but that we many times could do a better job of making available for everyone. What's really telling in this slide is that we're spending a lot of money on our high-tech acute care system, which contributes only about 10% overall to the health of our population. So if we could save some money in that acute care system, we would have more money to spend on covering everybody and more resources to put into other priorities like housing, nutrition, education, transportation, the environment, the things that really contribute more to a healthy population. Taking a closer look at factors in the community that affect health and that tend to be more present for lower income communities and persons of color, you can see that these factors suggest a number of areas for improvement in our public policy decisions and that the link being made by advocates for shifting resources from policing, for example, to human services are in those areas that would contribute to health overall as well. And I just showed this slide to make the point that equal is not always equitable. Some people need a little more help than others, and we as a society have an obligation to remove some of the structural barriers to the opportunity for all of us to be healthy. So let's take a look at the video, Medicare for All with Dr. Ed Weisbart.
The way we finance healthcare keeps wages flat and costs businesses a fortune. Healthcare costs pose a real existential threat to the American economy. There is no doubt at all in my mind that the best way to ensure the competitiveness of American business is with a single-payer healthcare system.
Let's give the taxpayers of the United States a better return on their investment, which means Medicare for All.
Medicare for All will serve to organize and measure the best of our energies and skills to improve American healthcare.
People are talking a lot about Medicare for All, but the phrase means different things to different people. That's not surprising. Many of us don't know a lot about Medicare, so let's talk about Medicare. I'm Dr. Ed Weisbart. I'm a family physician, and I'm a member of Physicians for a National Health Program. We all support building a program based upon improving Medicare and expanding it to every American. Before Medicare was enacted, only 51% of Americans over 65 years of age had health insurance. Many of them died because they couldn't afford health care.
We are behind every country pretty nearly in Europe in this matter of medical care for our citizens. But we are now talking about doing most of the countries of Europe did years ago.
President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage.
Today, 59 million Americans are covered by Medicare. It's literally a lifesaver for seniors. Most physicians today support Medicare for All because we see firsthand how broken our healthcare system is.
Does that hurt you at all?
No.
Commercial insurance companies second-guess our clinical judgment on a daily basis.
We're going to get you set up to see Dr. Miller for that injection of your knee.
Thank you very much.
If I write a prescription and they want more information, my nurse has to call up that company. It's not uncommon that they spend 30 minutes with one appeal. So we're trying to figure out the game so that we spend the least amount of time doing that kind of baloney.
Commercial insurance companies add bureaucratic waste to our medical offices and intentionally create barriers to our delivering medical care.
Doctor wanted an MRI ordered. Patient was in excruciating pain, unable to walk. We attempted the MRI and we were told no. The basic Medicare product through the government is just a very easy to follow plan. There's no prior authorizations required. We know what the coverages are. We know what to expect. We know claims payments in and out. We're good.
The typical American physician spends nearly $100,000 per year dealing with insurance, negotiating pre-approvals for tests and treatments, rewriting prescriptions, and generally doing paperwork that does nothing to improve your health. Most of these costs are generated by commercial insurance companies. Beside the waste they create in our medical offices, insurance companies also create tremendous waste in our hospitals.
The administrative costs have skyrocketed. We have a sort of lopsided emphasis on billing and money rather than an emphasis on adequate patient care.
We have people who can't pay, people who have this insurance, people who have that insurance. So there's nurses whose full-time job is to help get authorization so that a patient can get the care they need. And that's ridiculous.
From a nursing point of view, insurance companies are a parasite. They are a complete impediment to our care.
Commercial insurance has become so complicated that the 900,000 hospital beds across the United States require hospitals to employ 900,000 people just for billing and insurance-related work. That's one billing person at the foot of every hospital bed.
If we did not have that money administratively siphoned off and put it back into patient care, there would be more than enough money to have adequate nurse-to-patient ratios and thus improve the quality of care and reduce nurse burnout.
Commercial insurance companies are disruptive middlemen that add cost while diminishing the quality of care. We could make the healthcare system much simpler and much less expensive if we had Medicare for all. On international comparisons of preventing death from curable diseases, the United States ranks dead last out of 19 advanced countries. Our low ranking is primarily caused by barriers to getting health care.
Emergency rooms are always crowded now with patients who don't have insurance. Patients don't have primary doctors. Because many people have delayed care for so long, by the time they do come to the emergency room, their health condition has deteriorated to the point where they need to be hospitalized.
1 in 3 Americans can't afford to get basic care. But when my patients make it to age 65 and join Medicare, this catastrophe reverses. My patients can suddenly get that biopsy, that cardiac stress test, or even that treatment for cancer. One of my 64-year-old patients needed urgent surgery to open up a blocked carotid artery, but she told me that she would pray and wait until she turned 65 and got Medicare. Doctors like me see this over and over again, and it makes us sick and frustrated and angry, and we're always so relieved when our patients reach Medicare age. Compared to commercial insurance, Medicare is more effective at cost control. Commercial insurers typically pay at least 20% more than Medicare for the same services and devices. In the case of hospitals, the Congressional Budget Office found that, on average, commercial insurers pay 89% more than Medicare. Payment contracts between hospitals and commercial insurance companies are done behind closed doors, in secret. In Massachusetts, the Attorney General had to issue a subpoena to get access to this secret information and find the real cost of healthcare. They found that pricing for procedures could be up to 10 times higher in some hospitals. They also saw radical price differences within the same hospital depending on who was paying. In comparison to the chaotic system of commercial insurance pricing, Medicare sets payment fees based on a thoughtful process of evaluation of services.
If we took those prices and applied them automatically to the entire private health insurance system, we would save billions of dollars in this country, just with that one change.
In addition to saving money by sensible pricing of services and devices, Medicare also eliminates much of the waste seen in commercial insurance. Medicare operates with an overhead of 2%. Compare that to commercial insurance companies that typically operate with an overhead of 15% or more. That's more than 7 times the overhead cost. Medicare operates today with just 6,100 employees, compared to 470,000 employees in the commercial health insurance sector. Medicare does not have thousands of employees working in sales and marketing and claims denial. Medicare does not need to earn an ever-increasing bottom-line profit to satisfy Wall Street. Medicare does not pay multi-million-dollar executive salaries. Hospital administrative costs run $667 per capita per year in the United States. That's 4 times as much as the $158 they spend in Canada. No other country comes close to wasting money like we do, and it's primarily driven by our chaotic and needlessly complicated commercial health insurance system. Americans with traditional Medicare can go to almost any doctor, any hospital, anywhere in the United States. Traditional Medicare patients don't have to worry about restricted networks of doctors and hospitals. Americans with traditional Medicare are free to choose where and how they get their health care, even crossing state lines whenever they want to. No permission needed. Commercial insurance is totally different. It typically limits your choices.
As a matter of fact, we don't choose our insurance companies in general. It's your employer, if you're getting your insurance through an employer, that chooses the insurance company. And that's really not based on the quality of the insurance most of the time. Most of the time it's based on the cost to the employer.
Medicare for All is the only way to get the freedom of choice that Americans want. The main things we need to improve in Medicare are to make the benefits more comprehensive and eliminate the co-pays and deductibles that make many Medicare patients need to buy a supplemental policy or join an Advantage plan. The so-called Medicare Advantage plans are completely different from traditional Medicare. These plans are sold by commercial insurance companies and add both cost and complexity to the system. Advantage plans operate at overhead rates that are 4 times higher than traditional Medicare. Medicare Advantage plans waste our tax dollars. They manipulate Medicare into overpaying. One study showed that between 2008 and 2016, these overpayments added up to $174 billion. Expanding traditional Medicare can offer all of the benefits of the Advantage plans without the disadvantages and the added costs. By eliminating bureaucracy of commercial insurance and empowering Medicare to set sensible fee schedules for things like prescription drugs, the savings will fund the needed improvements. The conclusion that so many physicians draw is that when we finally expand our Medicare system to our entire population, the health of the United States will skyrocket to the best in the world. Improved Medicare for all. It's simple, it's prudent, and it's proudly American.
Well, I hope Dr. Weisbart was able to convince you that what we are doing is incredibly inefficient, wasteful, and that it actually poses a threat to ourselves and our families, our businesses and our communities, and that there is a better way. I made this slide some time ago to show the piecemeal way that we try to provide coverage right now. Many of the things on this list are public programs that were put in place to fill the gap in our employment-based model. So notice, for example, the 1,100 federally financed public clinics, which most people know very little about, but that actually cover millions of low-income individuals and families, the uninsured, the underinsured, undocumented persons, the homeless, and more. These are the people, and these are the organizations that are trying to keep people out of expensive emergency rooms and also trying to provide decent primary care. So this is our multi-payer system. It isn't a system at all. It's really a patchwork, only it still has big holes in it. As the video tried to show, and I have some numbers behind that, we spend more than 1/3, or 34 cents out of every healthcare dollar is spent on non-healthcare activities. Our multi-payer system imposes an enormous administrative burden on hospitals, clinics, and providers, in addition to the overhead incurred by third-party payers. And these costs are passed on to all of us. So that's $1.2 trillion every year at current spending levels. What if we could cut that even in half? That would be $660 billion that could be used to cover everyone, improve benefits, and reduce the cost of our system overall. That's even before we put our one big customer, the government, in charge of negotiating prices on our behalf to reduce the outrageous profiteering built into our market-based system. And it isn't as though we haven't tried. We have spent over 40 years trying everything but the one thing that works well in most other developed countries around the world. Costs have just continued to go up. If you are still persuaded that we should keep trying harder, that if we would just run our healthcare system like a business, please read Elizabeth Rosenthal's book, in which she explains that the medical industrial complex is literally a study in market failure that makes money the metric of good medicine. We are now faced with the challenge of reversing decades of programming designed to make us believe that healthcare is a business and that government can't possibly be trusted to fix it. But now that we've tried everything else, Winston Churchill is supposed to have said that we can always trust the Americans to do the right thing after they have exhausted all other possibilities. I think we're there, and it's time for real reform. Just like the thousands and thousands of people marching in the streets these past few weeks, pushing for changes in policing, and other people over the decades pushing for real change in a whole range of progressive issues, advocates for real healthcare payment reform believe that we're past the point of accepting measures that would just slap another Band-Aid on the hemorrhage of money currently flowing into the medical industrial complex. So healthcare payment reform in the United States is not new. Advocates for a national health plan have been working on this for over 100 years. Medicare for the elderly and the disabled, and Medicaid for the very poor passed in 1965. That's 55 years ago. Both the Social Security Act of 1935 and the Medicare-Medicaid Act of 1965 were supposed to be followed by further, more comprehensive legislation. This was very effectively blocked by powerful opposition from the AMA, by Southern whites who did not want a system that would desegregate our entire healthcare system, at least until the Medicare and Medicaid law finally passed in 1965 and accomplished that. And eventually blocked by well-funded lobbyists whose business interests would not be served by a payment system designed to cut prices and control prices. Oh, I'm sorry. So no sugarcoating this. We have on our side the policy, the economics, and even public opinion which favors Medicare for all when the question is asked correctly. But we are up against powerful, well-financed opposition to disrupting their business model of the for-profit side of healthcare, the big health systems, and frankly, those who feel their incomes would be threatened by reform. It will take a massive social movement to overcome the big money, ideology, and fear of change. If there's any good news in all of this COVID-19 crisis, it's that the status quo is getting harder to defend. Well, this is why there's so much pressure to do what is politically feasible. I ask you to beware of incremental change, and both parties try to hedge rather than go for real reform. It's easy to get mired in smaller pieces of legislation, but they all take time, energy, and political capital. So why not spend that on a real fix? Just a note about I'm really sorry. I'm keeping my phone beside me so that I can be in communication with our host. But anyway, just a note about the belief that a public option instead of single payer Medicare for all solution is a more politically feasible middle ground. I don't doubt the sincerity of anyone who is working for universal coverage, but this is the kind of catch-all term that stands in for a publicly subsidized insurance plan, likely to be administered by a commercial insurance companies or some similar variation, but it's really intended as a way around eliminating private insurance companies. So be aware that when you hear somebody pushing a public option, this will eventually result in the more expensive, higher need patients getting shifted to public programs, with private insurance companies cherry picking healthier patients. And these programs will lack the broader risk pool needed to make the system viable. Costs per patient will go up. The public program will become too expensive and it will fail. People will then conclude that that government thing didn't work. So it's also time to acknowledge that the ACA was a good start, that it is working as designed. It does cover more people, but it left a market in place. And it doesn't have the tools needed to bring down prices. And that we will never control administrative costs until we eliminate the multi-payer system. So given all this, what's the answer? Well, our first Republican president said that the legitimate object of government is to do for a community of people whatever they need to have done, such as infrastructure, schools, charities, and government functions, where combining our resources would be more efficient and effective. I would argue that we've already decided that it works well for us to do a lot of things together as a society. None of us could afford to pay for all the services on this list separately, yet we count on them to be there, and we fund them with our system of taxation. If we looked at healthcare the same way we look at public schools, infrastructure, police and fire protection, disaster relief, the common defense, agencies of government, we could design a payment system to fund a healthcare delivery system that actually meets the needs of individuals, families, communities, and businesses, instead of the demands of the medical industrial complex. I mentioned earlier a dual track of legislation toward a national health plan. A number of states are working on state-based health plans, including ours. Bills have been introduced for a Minnesota health plan in both the state House and the Senate, and for a national health plan in both houses of Congress. While it would be more efficient to pass a national health plan right away, it's possible that the states will have to show the way. So I'll stop here and take some questions.
Thank you, Anne. It looks like there's a couple of questions. Feel free to submit other questions. So I think the one question, I think the essence of the question is that how do you respond to the argument that Medicare for all or government-run healthcare would lead to reduced access to coverage?
Oh, I think that's pretty easy. First of all, we know that we can cover everybody for no more than we're currently spending and probably less. But we will, if the concern is that more people accessing the system is going to result in not enough providers. All of the legislation proposed also includes provisions for workforce development. We know we're going to need more primary care physicians in the pipeline. We know we're going to need maybe more nurse practitioners. We also know that both legislation at both the state and federal levels would actually address the unstable financing system that hospitals in urban underserved areas and rural areas are currently experiencing. So there are provisions to stabilize and make sure that hospitals and clinics around the country, including in rural areas and high need urban areas, have the clinics they need, the providers they need, the types of providers that are needed around the state and around the country, because there are deliberate provisions to encourage the type of providers that we are now experiencing the lack of, including things like dentists in rural areas, mental health providers. So I'm pretty confident that a system that would take a look at overall health needs of individuals, communities, and states and regions would address the needs better than a system that is only looking at its bottom line.
Thank you, Ann. The next question is, how does Medicare for All affect the incomes of healthcare providers?
Well, the experience in the Canadian system is that the people who are the most concerned about this are physicians, and they're doing just fine. If you take away all the administrative costs of running a practice or a clinic, they find out that they can see more patients and reduce their administrative costs. Nurses are doing well. They would still, hospitals and clinics would be able to be funded with global budgets that would assure income stability for nurses, therapists. Providers would have the choice of being salaried or fee for service, so they can decide which is the better choice for them. Physicians are going to have physician boards established to determine fair compensation. So the goal of these changes is not to reduce the salaries of healthcare workers. The goal is to make healthcare available to everybody and accomplish savings by reducing administrative waste.
Ann, you mentioned global budgets. Could you go into a little bit more detail about how that works?
The hospitals and clinics, so both, guys, I apologize. I'm sorry. The global budgeting process is particularly, it's described really well in the federal plan. Hospitals and clinics would be able to submit requests for their annual, their operating expenses based on the history of the last 3 years of operating expenses. So we separate capital expenses, which are big projects and building, and there's a special fund for that. Global budgeting means that hospitals and clinics can submit a budget for what they really need to keep the doors open, pay their people, keep supplies on the shelf, keep the lights on, and they can also submit requests for funds if they need programs added to meet the needs of their community.
Thank you, Ann. Here's another question. In your opinion, how do we get mainstream media to cover improved Medicare for all?
Oh, wow. You mean you know, I think it's kind of up to us to start demanding that they do a little less hand-wringing about you know, what they what the common talking points are, and really fairly cover what we believe are the options that we're putting on the table. A national health plan, such as is proposed by Jayapal Sanders in the Congress, and the Minnesota Health Plan. That's a really big challenge, but I realize that I think we as a public need to start asking for more accurate coverage. It turns out that it's easier to get coverage, it seems like, for the things that people believe kind of perpetuate a narrative, and it's really going to take all of us to help flip the narrative.
Thank you. Next question, there's a couple of questions here. Which elected political leaders in Minnesota support Medicare for all?
Are you talking at the federal level, or, oh, Medicare for all would be the federal level. So, well, we have a lot of work to do on that area. We only have one member of Congress in our Minnesota delegation who actually is on the bill in the House. That's Representative Ilhan Omar in the 5th Congressional District. So we have a lot of work to do to push our other members of Congress and our two state senators, our two federal senators, U.S. senators. I want to back up too on getting publicity. It doesn't hurt for us to write letters to the editor, you know, and to push local channels to cover this issue. Agree to be on panels for panel discussions. Yes, and pushing our legislators. Well, that's why we organize, and that's why we invite you to join us, is because it's going to take constituents pushing their members of Congress, and it's going to take constituents pushing at the legislature as well. We also have to have a legislature that is friendly to health and human services. Think election 2020.
Do you want to just comment on how you would find out who in the state legislature supports the Minnesota Health Plan?
You can go to the bill numbers. I listed the bill numbers. It's House File 1200 and Senate File 1125. And if you go to the legislative homepage, you can open up the bill numbers and see who's all signed on to the bill. And actually, I think I probably could do a little digging and find out on the Senate side, only a certain number of people can sign on to a bill, and on the House side, only a certain number of people can sign on to a bill. So when it gets full, they have to open up a new number, and I think that's happened in both cases for the House and Senate.
One thought too is you could contact your state rep or state senator and ask their office if they support the Minnesota Health Plan.
Right.
And if they don't, you can suggest that you would like them to.
You can thank them for their support, and then, or you can encourage them to sign on to the bill.
What would it take to get more allies in this fight?
Wow. Well, we're going to talk about that a little in a little bit right after. But it's really all about each of us inviting more people to the fight. We are working really hard to reach out to the public. It's been now, without being able to do in-person events, we were doing tabling at park events and farmers markets, doing speaking engagements. So some of those things have to be done in the virtual world right now. But each of us really needs to be talking to our friends, family, neighbors, voters, and candidates and elected officials as well. And pushing this issue, use our personal networks and try to invite more people to join us.
And then any thought on the best case scenario of how many years it would take to achieve universal health care like this?
Well, I'd love to create a timeline myself. That's kind of something I've had in the back of my mind. But we have bills introduced in both the Senate and the House at the state and federal levels. We are not able to even get a hearing on bills like this until we have a legislature that is more friendly to reforming and fixing how we pay for health care. So if we could get a mix in the legislature, get the right majority, then our next task is to push for hearings. So let's say we were able to get enough seats in both houses that we feel like we could get hearings, that we could have hearings by as early as next winter. And perhaps we could have hearings over a session or 2 sessions. It would take some work, and I'm being very optimistic, but with a lot of work, I don't see why we couldn't pass a bill and get this going in perhaps 2 cycles, 1 or 2 cycles. I think we need to set the goal and kind of work backwards. And these legislators and the governor, by the way, need to hear from us. Don't forget that the governor's support will help a lot. And we don't have to wait for an election cycle to write a postcard to the governor, especially now during this period of high unemployment. I think it's time to make our case. This employment-based thing is not working out so well.
Okay, next question. Could you comment on how much Joe Biden is on board with Medicare for all?
Well, I just listened to the fundraiser yesterday with former Vice President Joe Biden, our presumptive nominee for president, and former President Obama. And of course, he again reiterated his goal of expanding and improving and strengthening the Patient Protection and Affordable Care Act. I can certainly understand that it was hard to pass that bill. They probably did the best they could, but it really is a market-based solution. It brought more people in, and covered, but it's at really great taxpayer expense. It really didn't deal with prices and administrative costs. So really our next move is to push hard for them to consider that that was just a good start. I think he has supported, I think he's actually agreed with Senator Sanders to drop the age of Medicare to 60. Does that ring a bell with anybody else? Which is kind of a little step that I even wasn't expecting. So we can believe that Senator Sanders is going to be pushing, and we really need to push these senators in a more progressive direction. I'm optimistic because he's got some progressive positions on other issues like gun violence prevention and the environment. So not yet, but you know, that's why we have a movement, so we can push.
Okay, next question. How specifically in Minnesota do you see possibilities for coalition building with the Black Lives Matter movement to honor Minneapolis City Council VP Andrea Jenkins' call to understand intersectional racism as a public health crisis? Do you feel the call for Medicare for all shares specific similarities to calls for divesting from police and investing in communities? For example, divesting from our current medical industrial complex to invest in direct patient care.
I think that person has the statement down right there. I see a lot of potential. I think we've had some conversation within Healthcare for All Minnesota already, trying to think about how to make those connections and make some meaningful connections with people who are engaged in the entire progressive agenda. I think really one kind of depends on the other. It's really hard to to have stability in communities without a stable, well-funded healthcare system, and vice versa. So and we would appreciate help. Anybody out there who thinks they have, is willing to make great connections and help us forge some of these relationships.
Okay, I'm going to do 2 more questions. One is about Greater Minnesota. Greater Minnesota has been difficult to get on board for Medicare for All. What are your ideas to help reach this population?
Well, when we could do in-person events, we were doing some speaking engagements in Greater Minnesota. We've worked to forge relationships with groups like the Land Stewardship Project for farmers and members of rural communities. We're working on a relationship with the Minnesota Farmers Union. We would love to have anyone out there who has friends or family in rural Minnesota to even make the connection and give us names and numbers and invite them to listen in on some of the educational offerings. One thing that the reliance on virtual events has done for us is that we are able to reach out to Greater Minnesota without the barriers of distance or weather. So we just need people to invite anyone they know to join in these educational offerings and kind of get a flavor for what we're doing so we can help them feel connected. I really think that the plight of rural Minnesota, with hospitals and clinics being financially kind of stressed and lack of certain providers in rural Minnesota, argues for the fact that a more comprehensive system would be helpful. It's really a challenge to get the word out. So. Oh, you're on mute. Oh.
How would you find out which state legislators are opposed to the Minnesota health care bill? Who are the biggest challenges there?
Well, to veer into being political, I guess, we're officially nonpartisan. So I kind of try to say that we need a legislature that's friendly to health and human services. But there are kind of 3 camps. I think there are people who are with us on this. There are people who are a little hesitant because they're worried that it's not politically feasible yet. And they tend to be in the DFL party. There are some conservatives who are not yet convinced, and really we have no support that I know of amongst Republican members of the legislature. We also have to push the governor a little bit. Just I'll make another pitch there. His proposal last year was this One Care Minnesota that was really going to be yet another insurance plan kind of layered on the multi-payer system, and it would offer some additional supports for rural Minnesota, but I just failed to see how it would have helped overall in the problems of cost, quality, and access. Would not have reduced administrative costs, and it really would have left the market in place. Didn't really have it had some provisions for negotiating prices, but not very strong.
And I will just suggest again that feel free to contact your own state legislators, your state rep, your state senators. You can call them anytime, you can email them anytime, and that's where you have your power. Your power lies with who represents you. So if you go contact some other rep that does not represent you, they're really not going to care that much what you think. Who cares what you think is your own rep and your own state senator. So that's where your power lies.
Sorry, exactly. And I wouldn't give up on someone who you assume is not with us, because it's their job to listen to your concerns. And if this is important to you, go ahead and talk to them, regardless of which political party they belong to. But like Dana said, really focus on your own representatives, because those are they are really most interested in listening to their own constituents.
Okay. All right, our Q&A portion is done, so move on. Let's move on to the next call to action.
Okay. So what can you do to help? I hope by now that you're asking yourself how you can help. And we touched on this a little bit, but it really is all about numbers and intensity. And you probably noticed over the last few weeks, even though the cost of healthcare is a huge concern for a majority of Americans and a top issue for voters, at least according to the polls, real reform is not going to happen without a lot of involvement from the public. Building a movement for change means that we have to educate and engage the public, organize and build our base of support, and then pass and implement legislation. We have a lot of opportunities for volunteers, of course, but a top priority for the next few months is going to be the upcoming election. So talking to voters and supporting candidates who are with us on this issue, as well as the whole progressive agenda. Make a pledge to learn what you need to know to feel confident in having those conversations with friends, family, neighbors, voters, candidates, and elected officials. Campaign time is a good time to establish yourself as a trusted, it's called being an honest broker for your issue, somebody they can go to when they have a question, or they know you can find the answers. It's a great time to become known to candidates. If you do some work for them on their campaign, they will remember you. If you're not already on our email list, please go to our website and put your contact information under the column that says join us. Also like us on Facebook so you get event notices, and then share those Fix-It videos with others. There are the short ones like we showed today, and then there are a little bit longer videos that are really good explanations of the current system and how we could improve it. I especially recommend reading Healing Healthcare by John Marty. Senator Marty is not only the chief author of the Minnesota Health Plan, but he does a great job in this book of explaining the proposal, what it would take to get there, how we would transition in a responsible way. It's the only piece of legislation I know of that has such a great explanation already laid out for us. Share events like this one and invite others to join this movement. Just like we talked about, this is how we grow, and that's how we'll win. Check out these organizations. They're all working toward a national health plan. National Nurses United in particular has an excellent resource with frequently asked questions. You can also sign up for webinars and updates with them as well. Visit the website for Physicians for a National Health Program, which is a wealth of information. I go there a lot, especially for the economics of a Medicare for All system. Take a look at the Kitchen Table campaign with a different theme each month and actions to take. And finally, I can easily make the economic case for reforming how we pay for health care, but in the end, this is an issue that crosses racial, economic, gender, and political lines. Martin Luther King Jr., in his letter from Birmingham jail in 1963, wrote that injustice anywhere is a threat to justice everywhere. We are truly all in this together. So one last thing before we end. Unemployment is reaching levels not seen since the Great Depression. 2 bills have been proposed at the federal level to help. Both of these could be a path toward an eventual Medicare for all and are far superior to the proposals like reopening the insurance exchanges for people to buy insurance they can't afford with money they don't have, or subsidizing COBRA payments, which just sends more taxpayer money to commercial insurance companies. So get out your phone and take a picture of this slide so that you have the details. And as soon as you leave this meeting, go to the phone and call your representative and both United States senators. Ask them to vote for the Medicare Crisis Program, which would cover any U.S. resident eligible for unemployment insurance. And then ask them to vote for the Healthcare Emergency Guarantee Act, which would provide coverage for anyone currently uninsured and cover out-of-pocket expenses for people with insurance. So that's something you can do right now today when we finish. And last, this is my contact information in case you ever want to get hold of me personally. And I want to thank you again for joining us today. Be well. And then don't forget, our next webinar is July 15th. Is that right? Okay. So join us for that one. And what does a good activist do? You invite somebody else to join that event.
Thank you so much, everyone, for attending. If you have any other opportunities for us to give out information to other groups, we can do webinars like this for specific groups, please contact us. And this webinar has been recorded, so we will be making this available to watch. And in addition, the video can be watched on its own at the Fix It Healthcare website. And you will be getting a couple follow-up emails with resources that were mentioned today. So thank you again. And our webinar is now completed, so feel free to feel free to exit. Thank you so much.